First of all, thank you for being here, and thank you for inviting me. We will go through some ideas on how to use and how to introduce Emervel, a new filler from Galderma, in your arsenal of fillers, and especially with the previous fillers from Galderma, QMed, Restylane. This business, we have many doctors into this business. There are some core specialists, there are dermatologists and plastic surgeons that traditionally use this technique, but there are many other doctors like general practitioners, general surgeons, craniofacial surgeons, ENT surgeons, dentists, ophthalmologists. So it's important that we do a very comprehensive approach when we treat patients with filler. So in the past, we were mostly using surface treatment with the surface anatomy, with the dermatologic approach, and with short results. Now we're mostly doing contouring. We use, to go into the deep anatomy, we have a surgical approach, and we use to have patients coming for maintenance. As a rule, our patients used to come in our offices for retreatment every 3, 4, 6 months. So these were the standard treatments up to the 90s, mostly treatment of the nasolabial folds, superficial lines. But with hyaluronic acid in 1996, everything changed, since we understood that hyaluronic acid could be injected not just in the dermis, but even in the deeper layers, and have the same effect, even better, because actually when we inject HA, we don't inject the dermis, we inject the subcutaneous tissue, and there are some studies, you see this study, they were able to show that we are not injecting the dermis. We're actually injecting the subcutaneous tissue when we use hyaluronic acid. So from a surgical point of view, we're using fat for many years, and now we're using hyaluronic acid more or less the same way we use fat. Fat is used in large volume, is very safe and effective, is a biocompatible material, it has a good biostimulation effect on the tissue. We have a permanent effect of about 50% of what we put. Can be a repeat treatment, and it's cheap. But the way we do fat is deep in the fatty tissue, in the subcutaneous tissue, in the muscles, over the bone. So this is the way we're doing fillers now. And in 2004, we have the first volumizing filler on the market. That was Restylane Sub-Q. And that was the beginning of a different approach, a full face approach to treating the faces of our patients. So it's very important to know the anatomy and to respect the anatomy. And most of our treatment with fillers in aesthetic medicine are in the middle part of the face, the mid-face. You know that the upper third is territory for the botulinum toxin mostly, but also for fillers. And the lower third, from an aesthetic point of view, for a non-surgical point of view, is mostly a territory of suspension threads and a little bit for toxin and fillers. So we are shifting from surface anatomy, where we have superficial landmarks, to the deep anatomy. So just a few spots on deep anatomy, and I think that Dr. Stan will speak about the anatomy again after. So it's very important to know which changes affect the bony skeleton of the face, because we know from anatomy and from Mendelssohn studies that the changes in the fascial skeleton are mostly around the orbit, where we see the orbit it's enlarging in the upper and medial part and enlarging in the lower and inferior lateral part. And we lose a lot of volume in the mid-face, in the malar bones, and on the mandible. So this is important. I'll show you after how we can restore volumes of the bone with fillers. So this from another paper that was published some years ago. You see an old skeleton and a young female and an old female. You see how much bone is lost around the orbit, in the midface, and in the mandible. So this is the reason why the tissues sag, and because they lose support from the bones. And this is the enlargement of the orbital bone in this area. And in the midface, we see that we have the possibility of restore volume in the midface by putting some volume over the malar bones. And the mandible, around 80s, we have lost about 50% of the mandible structure. So it's very important that we address all these bony problems with our fillers, and I will show you after. Don't want to go through the anatomy, but just to remind you that we have sensitive and motor nerves in the face, mostly at the trigeminal face and the fascial nerve. This is the trigeminal nerve and the fascial nerve, but I think you know all the important part of the anatomy. But what is important is that we have some risky areas in the face when we do go deep with fillers, with needles, so that some areas are safer to be injected with a cannula. And you know that these are the supraorbital artery and nerve area and the supratrochlear artery and nerve area just above the inner canthus in the orbital rim. The dorsal nasal artery, we do inject a lot of noses with fillers at this time, so it's important to know that the dorsal nasal artery is a terminal artery, and it's important to remember that the angular artery and vein during the course along the nose, they are a terminal branch of the fascial artery, so this is a very delicate area. Another delicate area is the infraorbital artery and nerve area. I would say that if we have a nerve lesion, actually it's not so important. Probably the vessels are more important for fillers. And the fascial artery in the premasseteric area, it's another important landmark, and also the mandibular branch of the fascial nerve in there, and the mentalis nerve. But these are the most important practical risky areas in the face. But what is very important is that if we inject an artery, an accidental injection can provoke embolism, and especially in some areas, especially in the area of the angular artery, you know that we have a network where the vessels go directly to the territory of the ophthalmic artery, that is a branch of the internal carotid, and give way to another artery that is the central retinal artery. So especially in this area, should be very careful, and I recommend not to use needles in this area. That's why we use cannulas mostly in this area. And there are several descriptions in the literature of necrosis of the tissues and blindness after fillers. So according to this anatomy, it's very important that every time we put a needle deep down to the tissue, we aspirate. I didn't used to aspirate when we were injecting the skin, but now I strongly advise to aspirate, because we can get some bleeding in the needle. Even if the needle is very thin, we can see if we touching a bloody vessel. You know that fat is the most important areas to work with fillers, and fat is really important from infancy. We see that fat characterizes the shape of the face. You see that babies, they have a lot of fat, and we like babies for this reason, because they have chubby faces, puffy faces, and this is what we lose with time. And if we look at newborns baby, we see that all the lines and all the depressions that we will see when we age, they already there. So this means that these are not wrinkles, these are not signs of aging. It means that these are the anatomical structures, ligaments, muscles, and anatomical structure. So we cannot completely erase a nasolabial fold, because under the nasolabial fold there is a ligament. So we need to respect the anatomy, because we see that in this baby we see all the muscle that we treat with toxin. So they are already there. So they are not wrinkles. So it's important, if you look, the tear trough is here, everything is here. But if we look what happened with time, we see how much fat we lose from the face. And this is a famous guy who had everything in his life, sex and drugs and rock and roll, but the fat is gone. And after that, we understand that we need to restore volume where the volume was. So we know that the fascial structure includes both deep and superficial layers of fat. So basically, very basically, we have the bone, we have the deep fat, then we have the muscles, when we have the superficial fat, and then the skin. So on the left, you see the deep fat, and on the right, you see the superficial fat. And you know that these fat compartments are separate. So the basic concept from the anatomy is that we need to inject separately every single compartment, because the product doesn't spread from one compartment to the other. So right injection in the proper point, in the right place, you don't need to massage that much, because it doesn't spread, it doesn't move. If I inject this room, nothing goes in the room outside from here. So this is very important, because we should know where to go with our needles, because this is the main point, to save material, to save a product, and to do a right injection. If you look at the anatomy of the fascial fat, you see that this is the superficial fat, what we used to call the malar fat pad. And this is not just a single unit like it looks. And when you remove the fascial fat, you see that under, we see the orbicularis muscle, and you see the deep fat under the orbicularis muscle. Very basically, we have some very important areas of deep fat. Is the deep periorbital fat anatomy. We have three separate areas of deep fat in the periorbital. Is the suborbicularis oculi, the so-called SUF. We have a medial SUF and a lateral SUF. And we have the retroorbicularis oculi, that is called RUF, and the temporal fat. These are the areas of fat that begin to age first. Around 25, they begin to age. They begin to shrink. So we begin to lose fat around the eyes. And when we lose volume in this area, we begin to see the aging process around the eyes. Small wrinkles, retrusion of the tissue, and so on. And deep medial fat is another important area in the mid-face. And we have two separate areas of deep fat in this area, a more medial that is very close to the piriform opening of the nose, and the lateral compartment that lies directly on the maxilla. Especially the lateral compartment is very important for fillers, because when we fill this area, we get a good projection of the mid-face. And loss of volume of deep medial cheek fat leads to pseudoptosis. It seems that the tissue goes down, and it's the main cause of the nasolabial fold. It's important to know some differences between the superficial and deep fat. The superficial fat is attached to the skin, so it's mobile together with the skin. So we have a little bit of ptosis in the superficial fat. The deep layer of fat is fixed to the bone, is made of big globules with less septa, and this is a more structured fat. In the superficial layer, we have small lobules, and there is more connective tissue. There are more septa, and the fibrous septa connect the fat tissue with the mass and with the superficial layers in the skin. And if you look at a normal classification of nasolabial fat, you see that the nasolabial fold, you see that mostly the depth of the fold depends on the deep malar fat pads. So when you have a grade 3, you see that what we see most is the nasolabial fat, the nasolabial fold, but we see that we miss a lot of fat in the mid-phase. The tear trough is another very important area in this region of the mid-phase, and we should remember that at the level of the tear trough, the orbicularis muscle is directly attached to the periosteum, and there is no way to inject under the muscle when we are in the inner canthus. So when we inject this area, we're for sure under the skin. There's no way to go under the muscle here because the muscle is attached to the bone. When we are lateral, we have the orbicularis retaining ligaments that connect the orbital bone to the orbicularis muscle. So in this area, we can go under the muscle and we can feel deep in this area. So try not to go deep in the canthal area because there's no way to go deep in this area, and it's even much safer to stay superficial because you see the tip of your cannula and you are sure that you're not touching the vessel. The vessels there are usually deeper here. And the muscle junction in this area correspond to the superior border of the fat pad, of the malar fat pad. If you look at a young lady's eye, you see that the lateral part is pink and the medial part is darker. This is exactly the point of transition between the muscle, between the fat that covers the muscle and the muscle that is not covered by the fat. So when you see a young lady, you understand exactly the anatomy of this area. And this is what happens when we age. We begin to see the skin relaxation, the loss of volume, and we see the tear trough, we see the lid cheek junction, we see the malar mound. The malar mound actually is a small fat pads over the orbicularis muscle in between two ligaments. So this is a cul-de-sac, is a very close area. So if you inject this area, you will have swelling for sure because there is no way for the liquids to go out, especially if you inject hyaluronic acid. So if you want to inject the malar mound, always stay deep, stay to the bone. And then you see all the other groups that we see when we age. And when we move to the superficial fat compartments, we see now that all the superficial fat compartments are separate. And what is important to remember is that the malar fat pad is composed by 3 separate compartments: the medial, the middle, and the temporal. So this green area is actually 3 compartments. And what is important is that the nasolabial fat compartment doesn't lose volume with time. So what happened is that we lose volume in the lateral fat compartments. We don't lose volume in the nasolabial compartment. So it looks like we have a sausage when we age, but actually this is what we have when we are young and stay there when we are old, while the lateral fat diminish and goes away with time. And then we have fat in the forehead, in the jowl, but especially in the mid-face, these are the compartments that are really relevant for fillers. All these fat compartments are separate by retaining ligaments, and it's very important to know the borders of the fat compartments because into the retaining ligaments we have the vessels, and so if we know where to go with our cannulas, we can avoid the retaining ligaments, we can avoid the vessels, we can avoid bleeding. So very basically, these are very schematically the deep and superficial malar fat pads, so that we want to inject with fillers. So on the left you see the deep fats, on the right you see the superficial fat pads. Of course, the nasolabial, the more medial, should not be injected because otherwise we are going to worsen the situation. So as I told you, deep fat is fixed to the bone. and superficial fat is mobile with the skin. So we have no ptosis for the deep fat, we have ptosis for the superficial fat. And this is the timing of aging of the fat compartments. So the periorbital deep fat begins to age around 25 to 35, the medial cheek deep fat from 30 to 40, and then going on. And we see that the nasolabial fat compartments age very little or very late in time. So the basic concept is that the subcutaneous fat of the face is divided into compartments, and not all compartments age at the same time. So we should inject these compartments according to their level of aging. And we should remember that there is no diffusion of injected products from one compartment to the other. And for volume placement, we should respect the anatomy, because in the deep compartments, in the superficial compartments, and the septa that divide the compartments, these are the anatomic landmarks that should guide our filler placement. So my access points, according to the fat compartments, is that I inject the deep fat compartments where I want to go deep to the bone. I go always with a needle, and because I go directly vertical to the bone. And you see the yellow compartments, they are the superficial fat compartments, where I use mostly a cannula, because I want to work in a superficial layer in a, I would say, horizontal way and not in a vertical way. So these are my access points, and it's important that we respect the anatomy. We use a different access point for every single compartment. Sometimes you see someone who makes just one single hole and then move the cannula around like a windmill. That is wrong, because you are cutting the septa, so you are creating aging. So when you feel that your cannula stops, it means there is some septum. Respect the septum, come back, and don't inject more in that area. Don't try to cross the septum, because if you break the septum, there is some aging that you provoke. And when you inject, I told you I use a surgical logic in doing injections. So it's important to have a preoperatory marking for the deep layers and for the superficial layers. These are more or less the 3 points that we discussing even with Dr. Stan in the mid-face, in the periorbital area, and the injection should be exactly over the bone. So when you go to inject this area, you go through the skin, through the muscle, to the fat, and get to the bone. So especially for those people who are not surgeons, don't be afraid to go to the bone and touch the bone, because this is the way and the place you have to put your product. And what I do, you see, for each point, I just in the schema, just three different boluses. So I inject always not one single bolus, but small boluses of product, in order to avoid too much compression of the vessels, of the lymphatic vessels, and I will discuss a little bit after. And for the superficial layer, again, we should respect the superficial layer. So especially in the mid-face, we should inject the 3 separate parts of the malar fat pad separately. So these are the 3 areas of the malar fat pad that we can inject separately in the superficial fat pad. And what is important to remember, this is a very recent paper from Joel Pessa. He was able to show that the superficial lymphatic system is in the upper layer of fat. So if you put too much product in the subcutaneous fat, in the superficial fat, you will clog the lymphatic vessels, and you will have stasis, you will have swelling. So it's important that when we inject the superficial layers, we distribute very well the product. We don't pull the material in one place, otherwise we risk to have a compression of the lymphatic vessels, especially around the eyes where the drainage is very limited. What we see, what does it mean when we get to fillers? That we have subcutaneous atrophy, and that we have separate compartments. And it's important to understand the dynamic between the ligaments, the muscles, and the compartment and the lymphatic vessels. and to know very well the location of the fat compartments, because through this we can have best aesthetic result. We can spare material. We can not inject too much. And some special areas that we inject a lot with fillers are the lips and the nasolabial folds. This is the structure of the lips, but from an anatomical point of view, it's important to see the structure of the lips. And you see that we don't have a subcutaneous tissue in the mucosal area, and we have a little bit of muscle in the lips. And if we want to have a good improvement in terms of projection without duckbill effect, without too much pouting, what I do is always inject retromuscular. If you inject retromuscular, you get a very nice improvement of the volume without too much pouting, without too much duckbill effect. So if you need to do the contouring, you should inject the contour, of course. But if you need to do volume, what I do is to use a cannula and go retromuscular and release a small amount of product in the area. The nasolabial fold is a very important area for fillers. We have been injecting nasolabial folds for many years. But if you look at the anatomy of the nasolabial, you will see that from up to down, always we have a ligament, a fibrous ligament under the nasolabial. That's why we cannot fill completely. We cannot erase the nasolabial, because otherwise, if we inject too much, the ligament will tether the fold, and the product will spread laterally and will go into the nasolabial fold fat compartments, and that will worsen the situation. So that's why we should limit our injection mostly to the upper part, and the lower part is very dynamic because it's connected with the modiolus muscles, so there is little chance to erase the dynamic part of the nasolabial. So this is the most important point for the anatomy. Now we are lucky to have several books about the anatomy for fillers. These are some of the books. Not all of them are for fillers, but especially this and this are very useful for filler injectors. From an aging point of view, the anatomy is very important because we see these changes in the face, and these are not the only point. Of course, we have changes in the skin quality, in the skin texture. We can address those problems with other techniques. We have skin boosters from an injective point of view, but we can use lasers, we can use peels, and you know how to do it. And we have also sagging. Sagging, in the last year, when we understood that we had a loss of problems with the volume, someone said there is no sagging. Actually, sagging exists, the skin ptosis exists, so, but sagging is related mostly with the superficial fat compartments, so not for the deep fat compartments. And I won't go through to this. It's important to remember that even the marionette lines, they have a ligament. So we have ptosis of the buccal fat pad. We have a reduction of the jowl fat compartments. And the marionette lines develop in the area where we have the labiomandibular ligament. So the jowl creates in this area. So we should inject the mental fat compartment to reduce this, or we should inject the mandibular bone just to restore the volume of the mandible. This is the aging of the lip. You know that the upper and lower lip, they lose volume and they elongate. We lose the cupid's bow, and we lose the projection, and the commissure goes down.